Yeah, we can see that.
So aims and objectives for today. Oh, sorry. That was my alarm to remind me to record, is hopefully will help you guys understand and use the SBAR approach when you're communicating with other healthcare professionals. I'm aware that some of you guys are also medical students, soon to sit exams. So this approach that we're kind of going through is, what we would do in real life, but it's the exact same for a difference, for a change that we actually do. This is what they're wanting in an OSCE station as well. We're hoping that you guys will gain an understanding of some important factors when requesting radiology, speaking to microbiology, and also to be able to prioritize information when you're contacting someone else for help or information or whatever it is. It's really important as well, the prioritizing bit, as you're going to see, because it makes a big difference as to how you're coming across, how the urgency of the situation is coming across. So that's one thing that we are really hopefully going to hammer home for you guys today. So the SBAR approach, what is it? So everyone knows that it's this acronym, or hopefully most of you at least heard of it. It stands for Situation, Background, Assessment and Recommendations. And it's there as a framework for you to, so say if you're handing over a patient, using this framework in order to hand that patient over, but this is also really important. It's also there for you guys to know when you're receiving information, use this framework, because it means that you'll get all the information that you need over the phone and you don't miss anything out. It's also, it's one of these things where it's a bit like the A to E assessment. If you do the same thing every time, it's kind of designed so you don't miss things out. And we've all been on the phone when we're taking referrals from A&E, and you're not really getting the information that you want, or someone hasn't told you all the information that you want. But this is, if you kind of stick to this framework, hopefully you will be able to get all the information that you want and get people to come and help you. So as we said, it stands for Situation, Background, Assessment and Recommendations. So in the situation bit, well, initially you want to introduce yourself. So you want to say who you are and what team you're on. You need to be able to give the patient's details, so have those to hand. And initially you want to say what the issue is. So, I have a 57-year-old male in A&E with an abscess or an extensive facial laceration or a suspected PE, etc. And I would also give a very quick important, this is really important, a statement as to the stability of the patient at the time. Don't leave that to your assessment bit. So if the patient is, dropping their saturations, if they're hemodynamically unstable, and what we mean by that is the patient is they're tachycardic and their blood pressure is dropping, which means they're not really compensating for bleeding or sepsis. It's really important that you say that very early on, because it will catch the person's attention and gives them an idea of like, oh, actually, this is quite important. I really do need to listen, or I might just need to start walking towards where this person said that the patient was. For the background bit, you can then delve into a little bit more as to the history of the presenting complaint. So, you can say the patient has had breathlessness increasing across the last day, or 3 days of increasing swelling to the submandibular region, or something like that. Again, you don't need to go through the whole brief history, but a little bit of a story as to what's kind of led up to this event is always useful. Obviously, you want the patient's medical history, very important, and any medications that they may be on, which is also relevant to whatever you're handing over. And I've put social history here if relevant. It's not really all that relevant usually if a patient's on the ward having a PE and you're saying, oh, this patient lives with their wife and usually they work as a builder. But if a patient is confused and it turns out they normally drink a bottle of vodka a day, that could be relevant. So, when you're thinking about what you're going to be telling this person over the phone, have a think about what in that social history is relevant. Generally, all of the medical history will be relevant. For the assessment bit, you then want to go on to state what the patient's observations are and what they are in full. Don't say a new score. I know, like, this is very common. I get phone calls all the time where it's like the patient is using a 4. That means nothing to you. You need to know what the patient's specific observations are, so we know what sort of interventions we need to start implementing. Investigations, so which ones have you ordered? You can say you've ordered bloods, you've done a blood gas, you've ordered a chest x-ray, etc., etc. Any important examination findings. So if you have examined the patient, great. If it's been, say a patient is medically unwell and you needed some help, and one of, a colleague has examined the patient, again, do say who's examined what and where. And I've also put important negative findings in here as well, because it's really useful to know, so say like a patient has a very large neck abscess. It's important to know that the patient is not drooling, that, they don't have any voice changes and they don't have any difficulty moving their neck, because those three simple things mean that their airway is secure. And in the same vein that, if it's a medical issue and the patient is, has suspected sepsis, you can say, on a brief examination, they don't have any signs of any skin mottling, and they were warm and well perfused, that sort of thing. And then the recommendations bit is, so again, you'd say other things that you've done so far. So you've given some fluids or you've given some antibiotics, and it's, please can you come and see the patient? Please can you advise on what analgesia, antibiotics, etc. we need? And is there anything else that you'd recommend I do? Everyone happy with that so far? We're going to go over some worked examples of these. So for those of you who've been to our sessions before, we're not doing our usual case-based discussions. Shona and I have prepared some nice scripts for you. So we've got some worked examples of how to do this effectively and how to do it not so effectively, so you can see the difference. So without further ado, we will go on to our first case. Okay, are you ready, Shona?
Yeah, I'm ready.
Okay, so I'm going to be the SHO. Shona is going to be the lovely MedReg, of course. And we'll run the first one and then we'll see what you guys think about it.
Yep.
Okay.
Let's start. So, hello.
Hi, is this MedReg?
Yeah, how can I help?
Hi, can you come and see my patient, please?
I can't come and see the patient if I don't have any information on them, or I don't even know who you are, and I don't even know who the patient is.
Oh yeah, sorry. So I'm one of the MaxFax SHOs.
What patient do you want me to see?
So my reg asked me to get you to review one of our oncology patients on the ward.
And could you give me some background information on the patient?
Yeah, sorry. So his name's Alexander Rind, and he's a 69-year-old male, and he's on ward 13.
And what's the issue with him?
So he developed some shortness of breath and some leg swelling that my reg is a bit concerned about.
And what exactly do they think's going on?
I'm not sure. So he mentioned something about heart failure. Do you need to know his past medical history?
Yeah, that would help.
Okay, so he's got high blood pressure, diabetes, ischemic heart disease, and alcohol excess. Oh, and he's got an SCC of the right lateral tongue.
And why was he admitted in the first place?
So we removed the SCC and we've reconstructed part of his tongue.
And when was that done?
7 days ago.
And what's actually been done to investigate this heart failure? And has anyone done it? Has anyone examined the patient at all?
Yeah, so I've ordered a chest x-ray and I've asked the nurses to do some bloods, and then I was told to phone you. Yes, they did listen to his chest and they said he had widespread crackles.
And did you order a BNP?
Oh, I'm not sure.
Right.
Can you come and see the patient, please?
Get an ECG and I'll come and see the patient when I have time.
Okay, thanks. So what does everyone think about how that went? Is there anything that could be improved? Anything that was good about it? You can type in the chat or unmute, however you'd like to do it. Is there anything, so yeah, we weren't following the structure, Alice. Is there anything particularly that, yeah, I should have introduced myself? I didn't. I was just like, hello, come and see this patient, please. And especially when someone's unwell, you'd be surprised. It's actually quite common, and all of these things go out the window. No, I was not very efficient at all, Layla. And yes, I did have all the information. and the med reg had to ask basically all of the questions. So, and no, it wasn't clear what I was concerned about at all. I was basically just like, please can you see the patient? And my reg said this, my reg said that. So this is a really good demonstration of how, so like you guys can see all this information yourselves on the screen, and this is usually what we have on our handovers. And at the very least, you know, I could have made sure that before I made that phone call, I had the story straight in my head, or I could have asked my reg what specifically they wanted me to ask for and say over the phone. So yeah, that one was definitely quite messy. I'm glad you guys all thought that, because there have been times where we've done similar things like this and people were like, yeah, that's fine. We're like, no, it was not. So that's good. So we have a second version of this handover, which we will do if Shona is ready.
Yeah, I'm ready. Okay, let's go. Hello.
Hi, is that MedReg call?
Yeah, how can I help?
Hi, my name's Aisha. I'm one of the MaxFax SHOs. I was wondering if I'd be able to just discuss a patient with you, if that's okay.
Yeah, go ahead.
Thanks. So I've got a 69-year-old male on ward 13. He's called Alexander Rind. We're concerned that he's suffering an acute episode of heart failure. He was admitted under our care to have an SCC of his right lateral tongue excised, and that was done about 7 days ago. A few hours ago, he started complaining of being short of breath, and he's developed some ankle swelling, which was noted on the ward round this morning by my reg. So medically, he's got an SCC of the right lateral tongue, hypertension, ischemic heart disease, type 2 diabetes, and he drinks a bit too much. When we went to go and see the patient, he's breathless at rest. He's tachy at about 105, and he's got some pitting edema to the mid shin. My reg had a listen to his chest, and there were widespread crackles, but no added heart sounds. So I've ordered a chest x-ray urgently, and I've sent off some bloods, including a BMP. He is hemodynamically stable. My consultant and reg are quite concerned about the patient, and they think he's suffering this acute episode of heart failure, as I said before. And I was wondering if you wouldn't mind seeing the patient, and is there anything else that I can do in the meantime?
Okay, what are the rest of his observations doing?
Oh, yeah, sorry. So his blood pressure is 119/76, his heart rate's 105, his resps are 24, and his oxygen is 95% on room air, and his aparaxial at 36.7.
Do you know how his fluid balance is doing at the moment?
Oh, I'm not sure actually. I'll go and grab that chart.
Okay, if you could see about ensuring the patient gets an ECG and start him on 40 milligrams of IV furosemide, and I'll review him when I can.
Okay, thanks very much. I'll make sure that's done. Okay.
Great.
So any thoughts on that one? It was a bit better, wasn't it? Anything that again could be improved upon?
Anything that was good?
Sorry, Khaled, that's probably me just talking too fast. Yeah, Reggie, there was more of a clear structure and some clearer information. Is there anything that I did at the beginning that was definitely much better than the first one? Yeah, I introduced myself, and I also actually told him who the patient was. Yeah, and I asked, if he had time to discuss the patient. Because, as you know, MedReg is extremely busy, and sometimes they're in the middle of something. A one-liner, so that's what I was getting at. I said at the beginning what our concern was, which is really important, because they need to know at the beginning, why are we referring the patient? You know, is it something that they need to come running for? Is it just something that they can have a quick look at the patient's, online things and just give us advice? So yeah. Anything else? Yeah, so I said what investigations I'd done. There's one thing I was missing, wasn't I? The fluid balance. But again, I may not necessarily have known that I would have needed that when making the phone call. Yeah, and offered to do things while waiting. So yeah, basically this one, like we've purposely made, I mean, as we go along, they will get better. We've basically made them not all, perfect from the off. And these, very rarely are perfect, but the more of the structure you can stick to, and give as much information as you can, the better, basically. Okay, I'll move on to the next slideshow, and I'll let you explain the hints and tips.
Cool. So as we said before, it's really important that you have all the information in front of you. So want to know why why they were admitted in the first place, what their observations were, what their medical history and social history. As Aisha said, the only relevant social history in this person's case, he had alcohol excess, and that's normally relevant to mention. Maybe not so much, like we said, if it's PE, but think about what the presenting complaint is that you're phoning about, and also recent investigation results. So it depends what you're phoning about. Sometimes it's important to have bloods or microbiology results there, and you need to have your drug chart in front of you, because they might ask you about what dose of a medication a patient is on. If they might ask you what they're on, and if you don't have the drug chart with you, you're not going to be able to answer it. And they might ask you to stop or adjust doses depending on the situation. The nursing notes also has lots of useful things in it, like fluid balance charts and bowel charts, which you don't have in the medical notes. So again, it's normally good to be near the patient when you're making the phone call. So as I said before, medical history, it's important because it can impact, that in this patient's case, he just had a big operation, so that could impact his physiological reserve and put stress on the heart. So that's more likely to what's contributed to him developing the heart failure. So because it's such a long surgery, that's what's kind of going to be contributing to it. Make sure that when it's something like this, you've had a senior examine the patient as well, because you're not necessarily going to be comfortable looking at these things, saying, oh, that this person has widespread crackles, that kind of thing. And as we said, be aware that the med-reg can be very busy. They might not always be able to get to you right away, but document in the notes that you tried to phone them, and they'll just get back to you when they can. And yeah, that is the top tips for that case, but we'll move on to the next one. So yes, again, just have a little read of this, and then we'll go through another couple of examples.
The RFFF, by the way, guys, if anyone doesn't know what that is, that's a radial forearm free flap. So that's a soft tissue flap that we take from the arm to reconstruct the buccal mucosa.
Will we get started?
Yeah,
Cool.
sure.
Okay.
So I'm going to be the SHO again.
Yep. And I'm going to be the on-call microbiologist. Hello?
Hi, is this the on-call microbiologist?
Yeah, how can I help?
Hi, my name's Aisha. I'm one of the MaxFax SHOs. I was wondering if I'd be able to get some advice for one of our oncology patients, please.
Yeah, go ahead.
So we've got a 66-year-old female called Sally Jones. She developed a chest infection 4 days ago, and she's not really improving despite us giving her IV antibiotics. She's got a background of an SEC of the right buccal mucosa, which was excised and reconstructed 9 days ago. She's also got type 2 diabetes and hypertension. 4 days ago, when she initially started to deteriorate, we started her on some IV comoxiclav, and we also took a chest x-ray, which showed consolidation. We did send off some blood cultures and some sputum samples at that time as well. Unfortunately, she's not really getting any better. She's still spiking temperatures. So we're wondering if you'd be able to recommend a different antibiotic.
Okay, so I'm looking at the patient's results just now. Does she have any allergies?
No, none.
So it looks like there's been some cocci growth, which I would assume to be Streptococcus pneumoniae. Unfortunately, we don't have any sensitivities back yet. You said the patient hadn't improved at all on the comoxiclav?
No, she's still tacking, she's still spiking temperatures.
Okay, so because the sensitivities aren't back yet and the patient isn't improving, I'd advise changing the patient to the second line antibiotic for hospital-acquired pneumonia, which is tazocin. We'll contact your team once the sensitivities are back, and we'll let you know what antibiotic to use from there.
Okay, that's great. Thank you. Okay, so that's scenario, well, handover or request for help number 1. What do you guys think of that one?
Anything that was good, anything that was bad?
Nobody's saying anything showing us it must have been perfect.
Must have been perfect.
You wrote the perfect script.
Okay, well, we could just, oh, good introduction.
Yeah, so I actually introduced myself this time.
Yeah, that helps.
Efficient. Yeah, I followed the SBAR structure. I don't think I gave them all, no. Well, I said the important ones, yes, which was that she had a temperature and that she was tachycardic. Yeah, anything else? Did I mention the social history? Might be worth noting any allergies. Yeah, so I think you had to ask me, didn't you, Shona? Yeah.
I had to ask.
Yeah. No social and past medical history. I did actually, so I said the past medical history. I didn't say the social history because on this occasion it's not actually relevant, so we don't really need it.
Great.
So we'll do the second one and see what you guys think about the differences.
Hello?
Hi, is this the On-Call Micro?
Yeah, how can I help?
Hi, my name's Aisha and I'm one of the MaxFax SHOs. I was wondering if I could get some advice about one of our patients.
Yeah, go ahead.
So we've got a 66-year-old female on the ward called Sally Jones. And we're concerned as she's got a chest infection. So we started her on IV antibiotics 4 days ago and she's still deteriorating.
What antibiotics did you start the patient on? And was this a community or a hospital-acquired pneumonia?
I'm not sure which pneumonia, but we started her on IV Comoxiclav.
How long was the patient in hospital before she developed chest symptoms? And was it confirmed by chest x-ray?
So she's been in for 5 days and yes, we have a chest x-ray and you can see the consolidation on it.
Okay, so that'd be a hospital-acquired pneumonia then. So she's on the correct antibiotics that we'd recommend. Did you send blood cultures or a sputum sample? Hopefully we can see if there's any sensitivities back then. And does she have any allergies at all?
Oh, yeah. So both blood cultures and a sputum sample was sent 4 days ago when she first spiked temperature. And no, she doesn't have any allergies. Okay,
so it looks like there's been some cocci growth, which I would assume to be Streptococcus pneumoniae. Unfortunately, the sensitivities aren't back yet. You said the patient was deteriorating clinically.
Yeah, she's still spiking temperatures. She's tachycardic. So we're just a bit concerned because she's been on the antibiotics for 4 days and she's not really getting much better.
Okay, so because the sensitivities aren't back yet and there's been no improvement, why don't you switch the patient to Tazocin? We'll contact your team once the final sensitivities are back and let you know from there.
Okay, that's great. Thank you.
Cool.
So Hafiz, for OBS, can you omit the normal results and only mention the abnormal ones? So in real life, it depends who you're speaking to. You know, for the sake of, so say we'll see an example later when we're speaking to radiology. It's what is going to be important to the person that you're on the phone to. So that's why I didn't tell the microbiologist everything, because actually everything else is normal. But if you're speaking to a med reg or to your own surgical reg, whoever it is, they would want to know the full set of observations. I certainly do when people call me. But for the sake of, if it's an OSCE station, just say them all.
So what do we think of that last SBAR? Not as efficient and clear, yeah. Needed a lot of prompting. Need to be clear about whether it's a HAP or CAP, yeah. Does everybody understand the difference between a HAP and a CAP? Just on a side note. Assuming you must do if everyone's being quiet. Please explain. So you have hospital-acquired pneumonia and community-acquired pneumonia. So community-acquired pneumonia is when you develop it in the community, as it suggests. Hospital, you need to have been in hospital for 4 days. That's right, isn't it, Asha?
I think it's 48 hours.
Is it 48 hours? Sorry, my bad. I'm sure I read 4 days. Anyway.
Yeah.
You need to be in hospital for a certain number of hours to be classed as a hospital. And the reason that it's important is different antibiotics are used first line. So that's why the microbiologist would want to be, they'd want to know the difference.
Oh, there you go. Jonathan's.
Yeah.
Another one as well, yeah. So community-acquired pneumonias have a higher risk of atypical bacteria, as people are out in the community catching all sorts. So yeah, if it's you can add on clarithromycin onto the amoxicillin that we usually give first line.
Yep. What else? Anything else to add? Fine, we'll go on to the top tips then. So again, it's important to have all the information in front of you. Make sure, especially when you're talking to micro, you know what antibiotics the patients have been using and how long, and make sure you have a justification for it. There are trust guidelines where it'll tell you what the first line antibiotic is for a particular type of infection. And that's normally for good reason, that it's normally to do with, it's normally unique to each region because each region will have different sensitivities and resistances with antibiotics. There's also an app which I've recently discovered called MicroGuide, and that's very useful. And you can put in your particular hospital and they'll give you the first line antibiotic for different conditions, and it's updated frequently. So you're going to be giving them the most up-to-date antibiotic. Also make sure that you've checked for any sort of interim reports that they've taken samples from. It might tell you about what type of growths have been from the sample that you've taken. Make sure you've taken samples for any sort of sources of infection sites. So is it sputum sample if they're coughing, or is it a urine sample if they're having pain on urination, etc., etc. Another thing to think about is if a patient has a line in, which the oncology patients might, like a PICC line, something like that, you want to take samples from that line and send them away. And it's always important to rationalise the antibiotic cover as well. If the patient is already on coamoxiclav, do they need to be on metronidazole, for example? You already have a very good anaerobic cover with the clavulanic acid and the coamoxiclav. So unless you're told by a micro, you should normally just be on coamoxiclav. And then know what you're actually asking micro. It's normally going to be advice for antibiotics, so you need to make sure that you know about patients' allergies and if they're improving clinically, because they always say go by the clinical picture as well. Okay, case 3.
So you're now calling your MatsVax reg in the middle of the night, and we're swapping now. So I'll be the reg and Shona can be the SHO. I'll just give you a minute to read all of this information. By the way, everyone, I should have said this at the beginning, we've also purposefully kind of not put everything in the right order on these slides as well, not mixed it up too much, just to make it easier for you to digest, but so you can kind of have a think yourself when you're reading about actually how do you want to prioritize what you're saying and in what order, and for it to stick to the SBAR structure. Okay. Do you want to start?
Yeah.
Hello.
Hi, Aisha, it's Shona. I need you to come see a patient. He's a 27-year-old male. He was going to see his ex-girlfriend and then got into a fight with his current girlfriend over this, and she brought in some other males to this altercation, and the patient was beaten with a pole and stabbed in the neck with a Stanley knife on the right-hand side. The patient isn't actively bleeding at the moment. There's a slight ooze from the wound, but he's actually tachy at 131 and his blood pressure seems a bit odd at 100.
Sorry, did you say he's been stabbed in the neck?
Yeah, he's got a 6 centimetre laceration to the right side of his neck. It's not bleeding at the moment, but I think there's a hematoma.
Okay, how deep is it? Is it through the platysma? Whereabouts on the neck?
It's horizontal, about 5 centimetres below the border of the mandible. I'm not sure about the platysma. Shall I check?
No, don't disturb anything. That's okay. I'll come in. What else were you about to tell me? Sorry.
Yeah, so he's tachy at 131 and his blood pressure is 100/85, a respiratory rate of 21, and he's saturating at 99% on room air, and he's apyrexial. He's awaiting a pan CT to look for any other injuries, and his ABG shows his hemoglobin is 101 with no other abnormalities. A&E have taken other bloods with a group and a cross match, and the bloods aren't back yet. He's otherwise fit and well. He has known alcohol dependency and uses cocaine. It seems quite agitated now too.
Okay, yeah, that's understandable. Do you know what his GCS was?
15, I think.
Okay, I'm on my way in. So in the meantime, can you make sure that he gets a CT angio of his neck? If he's going for that pan CT, add it on and let someone know that he definitely needs it. So speak to radiology. And if they haven't already done one already, he needs an ECG because of the cocaine. So it might also be worth letting anaesthetics know that we potentially have a patient for theatre as well. Can you also keep an eye on that blood pressure? I'm presuming he's in resus, so we'll have continuous monitoring. If it drops any further, you'll need to get some help and possibly put out a major hemorrhage call because I think he's still actively bleeding.
Okay, will do. See you soon.
See you soon. Okay, so that was your first call about a neck stabbing to the reg at 3 a.m. Anything good about it? Anything that could be improved?
SHO in cam.
You, she was not a good enough actress. She wasn't.
No. I'm not sure I'd be calm in that situation.
No, so it's interesting actually because this is almost a word-for-word transcript of a call that I got last year where I answered the phone and then it was just a stream of information that I couldn't.
Yeah.
I just couldn't process it because I'd just been woken up and it was a story about someone fighting with their ex-girlfriend and something else and someone else turned up and then it was like, oh, actually he's been stabbed in the head, and I was like, oh, you probably should have said that first. But I was awake then once I'd realised that was what it was. So yeah, the remainder of the phone call, yes, was quite calm though.
Initially very fast speech, yeah, so that was on purpose.
Anything else she did well? Or not so well?
Yeah, either.
Everyone's very quiet tonight.
Oh.
So yeah, initially, well, I knew who she was. She introduced herself. Yeah. And so this does happen sometimes when we're all panicking, and if when something like this has happened and you've gone down to resus to be called down to something like this and you're just like, oh my gosh. And I think actually what happened was the person who called me was just reading off the notes. So rather than sitting and collecting your thoughts and being like, right, they've been stabbed in the neck, these are their obs, these are what I'm concerned about, this is the other bits and pieces that they need to know, because the patient had also been beaten with a metal pole, so they were awaiting this pan CT. So that again is very important information to know, because there's potential that they have other injuries. From our MATSFAT's perspective, or the facial injuries obviously would be our main concern, but we also want to know if there's other things, because if we need to take this patient to theatre and other specialties need to be involved, we need to call them and we need to tell them soon. Especially there are some other specialties like MATSFATs where we do our second on call off-site. So it may be that another registrar also has to come in. We do have another version of this one. So right, we'll do this one again.
Yeah.
Hello.
Hi, Aisha, it's Shona. Sorry to wake you. Shall I give you a minute?
Yeah, just give me 2 seconds. Okay, what's up?
I need you to come and see a patient urgently. He's a 27-year-old male in resus who's been stabbed in the neck with a Stanley knife and has a 6 centimetre laceration to the right-hand side, about 6 centimetres below the inferior border. It's oozing a tiny bit at the moment, but apparently bled a lot at the time of the injury. I'm worried he's hemodynamically unstable as he's quite tachy at 131 and a blood pressure of 100/85, and his ABG shows a hemoglobin of 101.
Right, okay. I'll grab my car keys. What are the rest of his obs like? Is he okay otherwise?
So his respirate's about up at 21, but his sats are fine at 99% on room air, and his temp's 36.3. His GCS is 15, but he does seem agitated. He's known to have alcohol dependence and use cocaine, but is otherwise fitting well. The laceration is about 6 centimeters below the inferior border on the right-hand side, and it doesn't go near the midline. And I think there's an underlying hematoma. I'm not sure how deep it is, and I don't want to disturb the clot. He was beaten with a pole too, no head or C-spine or facial injuries, but he's going to have a pan CT scan after they've finished examining him. They've sent some bloods off, including a group and a cross match, and his ECG was normal. Do you need me to order anything or speak to anyone else?
Yes, please. So he needs a CT angio of his neck so we can assess those vessels. If you could keep an eye on his blood pressure, just with that pulse pressure being a bit narrow, I think he's still possibly actively bleeding. You said he had a hematoma, right? The other thing is yeah, if you can give anaesthetics a call and let them know that we potentially will very likely have a patient for theatre as well, and I'll be there in 20 minutes.
Thanks. See you soon.
See you soon. Okay. So I think we can hopefully all agree that one was a little bit better. Anything that we could still improve upon from it though? Or what was particularly good about it? Yeah, she was very clear and concise. Yeah, she gave me a minute to wake up. So it's really important. And I'm sure, you know, if any of you guys do night shifts as well, you think about if you're having a nap and you get a bleep, you can't process if someone just starts talking. And certainly because I'm usually at home if I get called in the middle of the night, so I need to like get out of bed and things. So it's always useful just to give people a minute and be like, you know, let me know when you want me to start talking, basically, so they'll actually understand what you say. She said something in the first, well, she said a few things in the first sentence that were very good, but she was very clear about something that she wanted me to do. Come in. Yeah, so she said immediately, I need you to come in. So generally when you call someone, especially, you know, if you're calling your reg overnight, it's really good if you say, I need you to come in, or I'm just calling you for some advice, because the two things will kind of get slightly different responses on this end. You know, if someone calls me and says they need me to come in, I'll get up and I'll start getting change and things. If you need advice, I mean, it may change. You may start to tell me the story and I'll be like, actually, I think I should come in. But it's always really useful to be very direct about what you want, because especially like sometimes when, and I'm sure you guys will have the same, you know, if you're getting phone calls from GPs, dentists out in practice and things, where you're a bit like, I'm not sure what they want. Do they want me to see the patient now? Do they want me to put them on clip? Like, so saying the urgency of the situation, you know, I need you to come in. This patient has been stabbed in the neck. You know, it bled quite a lot at the time and she was concerned. The observation, she also said something as well that, you know, would definitely get anyone up and out of bed. She used a phrase. Does anyone remember what she said?
It was in the first little sentence.
Yeah, she said that he was hemodynamically unstable. Just for everyone to clarify, from these observations, can anyone see why I purposefully made it a little bit sneaky? Is that blood pressure normal? Or does it seem normal to you all? It's a bit of a leading question because I've asked you whether or not it's normal. So actually, no, it's not. So the systolic is kind of within normal, as is the diastolic. But what is abnormal about it is that the two numbers are too close together. So in a healthy patient, we call it the pulse pressure. It's basically the difference between your systolic and your diastolic blood pressure. So in a healthy patient, so if you took, you know, mine or Shona's blood pressure right now, in theory, the diastolic blood pressure should be no more or less than kind of 25% of the systolic. So because this systolic is 100, this patient's diastolic, we should expect, if it was normal, to be 75 or a bit less. If those numbers start to creep together, that's an indication that something is wrong. So either, I mean, if it widens or comes together in a patient like this who has been stabbed, The reason that these numbers are coming together is so the diastolic blood pressure is normal, but yes, his systolic is falling because he's bleeding or has bled. I kind of kept it normal on purpose because, you know, it says here he uses cocaine. So had he not been stabbed, his blood pressure would be higher. So we've mentioned this in other sessions, but it's always useful to remember what is likely to be normal for that patient. So say if we were expecting his blood pressure to be higher than, you know, the average with him taking the cocaine and whatnot, that's quite low. So even though it looks normal to you at a first glance, it's not normal. And she said something else as well that would also indicate that he's had significant blood loss, that his hemoglobin was 101. So normally in males, the normal one, the normal value, is the lowest bit is 135. It may be that he is a bit anemic, but, you know, say if she had a previous blood test to compare to, say if he'd come in for something else last week and actually his hemoglobin was 140, then we know that's a significant drop. He's lost a lot of blood, and is potentially still bleeding with that description of the hematoma, and because it bled a lot of the time and is now stopped. So she gave some really important information in like the first 20 seconds that she was talking. Does everyone understand that? Okay. Anything else that was good that she said or did? Anything on here that she missed out? You might not all remember. She didn't tell me what his social history was. However, in this situation, it's not important. If this patient was post-op and we were, you know, he was fit for discharge and we were hoping to get him home, that aspect of the no fixed abode, so him being homeless, would be really important. But over the phone at 3 o'clock in the morning, when he's just been stabbed in the neck, is not important to know at that point. But yeah, so that was the only thing really that we'd missed out of this one on purpose, just to demonstrate. Have a think about what you're doing, or what you're saying when you call. So some tips for calling MaxFax Reg overnight. So yeah, if it is the middle of the night, give them a couple of minutes. There is nothing that is so urgent if you're having to call someone in that cannot wait, you know, at least 2 minutes. If it can't wait that long, the patient's in a lot of trouble anyway, and there is going to have to be someone else in the building that needs to come and help, such as an anaesthetist. As I said at the beginning, like Shona, she said, I want you to come in. So be clear with what you want. So it's, I want you to come in, or I'm calling you for some advice. And those things are really useful, because especially when it's the middle of the night and you're half asleep, you need clear instructions as to, you know, what's going on and what you would like. As we say every single time, have all the information to hand. A lot of these, especially, you know, some of these complex injuries, we need to know what all the injuries are when you're handing over, because as I said earlier, we might need to contact other teams to come in or come to theatre. So what we don't want to be doing is taking this patient to theatre for, you know, a neck laceration, but actually he's got something else that another specialty could have come and dealt with, or would have wanted to have dealt with at that point as well. There are some things that can wait, certain fractures and things, and certainly, you know, if this patient had fractured his mandible as well, I wouldn't be looking to fix that at 3 a.m. But yeah, we do need to know what all of the injuries are, so make sure you've got all of that info in front of you. So yeah, and the other thing is try to ensure, if you can, that you've spoken to some of the other specialties, because if they've got multiple injuries or if they're medically unwell, that could potentially, you know, really change our treatment plan. This one is a little bit different because it's neck stabbing, so 9 times out of 10, if they need to go to theatre, they will go. Doesn't matter if they're withdrawing from alcohol, if they've just eaten a sandwich or whatever it is. But, you know, if there are other things going on, you know, they've got really bad heart failure and we're trying to decide, like, does it need doing, does it not? You know, anaesthetics would not be happy to give a lot of those patients a GA without an echo. So it's really important to make sure that we know who else needs to be involved. And not quite so important for this one, because we weren't really going to be closing this in A&E, but if your reg is coming in, make sure any equipment that they need is ready and it's there. So, you know, say if they're coming in to sort out a bleeding wound that can be closed on, you know, can be sorted out on A&E. Make sure you've got a suture pack, you've got your local anaesthetic, any topical tranexamic acid or topical adrenaline, and a bipolar. Usually you can get that from theatre if you don't have a portable one in the unit that you work in, and make sure it's all there when they arrive, because again, just make sure it makes everything much more efficient, make sure the patient gets treated much faster, and yeah, just kind of speeds up the whole process, I guess, because it's a little bit difficult if we're all still looking for equipment and things, and these things are never easy to find either at that time in the morning. So in that 20 minutes to half an hour whilst they're coming in, try and grab all those bits and pieces, and also ask them over the phone if there is anything that they need. We didn't do that for this one because it wasn't really relevant, because I wasn't going to be doing anything with this patient on A&E. But yeah, if it's something that can be sorted in A&E, make sure everything is there. So we're going to move on to our next and final handover / request for help. And this time, you're calling radiology everyone's most favourite task. So yeah, again, we'll just let you have a read of this for a minute, see what you think, and we will run our scenarios. Okay, just before we actually start, so the description of kind of her signs and symptoms. So she's got complete trismus, no external swelling, and a bit of pain on turning her head to the left and right. Does anyone have an idea of what is potentially causing that? Yep, she does have a high temperature as well. There's quite a few abnormal observations there, but yeah. Yeah, so this is a very typical septic picture on observations. She's tachycardic, the blood pressure is low, her respiratory rate's sped up, her SATs are dropping, and yeah, she's got a high temperature. But from the actual description of the clinical signs, does anyone know what this could be a sign of? Yeah, possibly a retropharyngeal abscess. Yeah, so yeah, basically it's a deep space neck collection. Yes, Alice, possibly peritonsillar. It can spread to another space, which we'll say it because that's what this request for the CT is. But yeah, it's really important to know that just because a patient doesn't have any external swelling, if they're presenting with other things such as trismus, which is a sign that the muscles of mastication are being irritated by something, and she's presenting with an infected picture, so we can presume it's pus, and she's starting to have pain turning her head, that means it's spreading into the deep spaces because it's irritating all of those muscles. So you don't need to have a big swelling on the outside to say, okay, fine, this is definitely a problem. They can sometimes present a little bit more subtly like this. So we'll run the first phone call. So hello, radiology.
Hi there, is this the on-call radiologist?
Yeah.
Hi there, my name's Shona. I'm one of the MaxVax SHOs. I'm just calling as we have a patient that needs a urgent CT scan, and I was hoping you'd be able to vet it for me so it can be done in the next hour or so.
Well, I need to know a little bit more.
Of course, her name's Carol James, hospital number 05123456, date of birth 12th of the 3rd, 65. She has a suspected collection in the deep neck space secondary to dental infection. She's admitted via ED today with no visible swelling to her face or neck, but complete trismus, so we're worried she has an infection in the pterygomandibular space that's compromising her airway. She was septic on admission too, so we've started some antibiotics and fluids. She's otherwise fit and well, no medications, and her EGFR was done, which was 78.
Okay, well, if you know it's a dental abscess, then what do you need a CT for?
We need to assess whether the collection is, where the collection is before we go to theatre, and due to sepsis, we want to take her to theatre as soon as possible.
Have you discussed this with your reg?
Yeah, she's been seen and assessed by my reg, and she requested I called you to vet the CT scan.
Okay, so I'm just looking at your request. What do you want the facial bones included for if it's a neck abscess? I think you need to cancel this one and just order a CT neck.
Sorry, it's because we need to see the teeth and if the infection spread from that. She hasn't been able to have an OPG because she can't open her mouth at all.
Okay, well, do you need it with contrast? Because you've ordered it without.
I'm not sure. Do you mind if I check and call you back?
Well, I guess I'm going to have to not mind if you check, because we need to know. But, we've got a lot of imaging requests to process today. I've got 3 people on hold. Can you be quick?
Yeah, I'm sorry. I'll ask my registrar and call back. Will we be able to do the scan soon, though?
Yeah, I mean, I'll get the radiographer to send for a porter as soon as I know what scan you want.
Sorry, I'll call you back in a minute.
Okay.
Getting grilled.
Yeah. How did that one go? This is definitely something that I must have done so many times as well. Just called and been like, oh no, I don't actually know what I want. Or not be entirely clear on exactly what it was, whether or not you needed contrast and various other things. Does anyone have any thoughts, any comments? It wasn't all bad.
No.
Yeah, so that was the main thing that was missing. I know it's silly because obviously we put these requests in and you have to write the justification in. But when you call the radiologist, they do want to hear that. They want to know why specifically you want the scan. They're getting hundreds of these phone calls a day to vet urgent CT scans. So it's important that you say at the beginning why it needs to be done and what it is, why exactly we want it. Yeah. Anything else anyone noticed? Yes, menopause it can be a nightmare. Yeah, you really do need to justify it. Obviously, it's a big radiation dose to a patient. It's not a small thing, and the radiologist wasn't quite wrong in saying, well, you said it's a dental abscess. You've even mentioned a space. Why do you want the CT? Yeah, and I don't think you actually said in this, Shona, either, like that the patient's
septic. No.
Septic. No. Oh no, you did say she's septic on admission.
Okay.
But yeah, it's not really. It's
not laboured.
Yeah, it's not at the forefront of actually this patient's very unwell. She definitely has a spreading collection into deep neck spaces. Should we give it another go?
Yeah, let's do it.
Okay. Hello, radiology.
Hi there. Is this the on-call radiologist?
Yeah.
Hi, my name's Shona. I'm one of the MaxVax SHOs. I'm just calling to make a CT scan request and we'd be grateful if you could get it done in the next hour or so because the patient needs to go to theatre urgently due to an airway compromise and we need the imaging to plan the procedure. Her name is Carol James, hospital number 05123456, date of birth 12th of the 3rd, 65. She suspected pterygomandibular collection secondary to a dental infection. So I've ordered a CT, facial bones and neck with contrast. She'd been unable to have an OPG as she's got complete trismus. So that's why we've needed to see the teeth on the CT scan too. She was septic on admission and is being treated for that. My reg assessed her and requested I order the CT and speak to you. She's otherwise fit and well, no medications, and we've taken her eGFR today, which was 78.
Okay, that's fine. Did you say you needed it with contrast because you've ordered it without?
Oh, sorry, that's my mistake. I'll put a new request through now.
Okay, that's fine. I'll let the radiographers know and hopefully we'll have her down here in the next 30 minutes or so.
Thank you. And would you mind reporting this urgently too, just so we can be sure which space needs to be explored?
Yeah, sure. I'll do that as soon as I've seen it.
Thank you so much.
No problem. Bye now.
Bye.
So that one was better, wasn't it? Anything that she did particularly well in that version that was missing from the first one? Nope. No prompting required at all. Yeah, she said exactly what she wanted and why. So it was, this patient has potential airway compromise. She needs to go to theatre, which is why we need this quickly. Why we want the teeth on it because she can't have an OPG, and we need to see which tooth it's coming from. And yeah, so the request to report, that's really important. I think it's something that people tend to forget to ask for. So if you're getting an urgent CT, yes, radiologists and consultants can, if it's something on there is obvious, you can see it. But if there's something on there that's subtle, it's always best to have a radiologist report on them to say whether or not there's, if there is a collection, something that they tend to comment on that you'll see, especially on patients with infections, is something called fat stranding. And what that means is it's inflammation. So it basically means it is spreading. It's not just, oh, right, there is a collection in this specific space. So that's why we need the radiologist to report it. Anything else that she did well? What is the difference between a contrast and a non-contrast CT? So I was going to explain that. So basically, contrast is something that if you inject it into a patient, it lights up areas of, well, anything that's high metabolically. So blood, infections, cancers. However, we normally use a PET CT for cancer specifically because that's showing cells that have a high uptake of glucose specifically. So if you get a CT without contrast, basically you can't really define very much from it, especially if we're looking for a collection of pus. If it's absolutely enormous, you'll see it because you will just see one blob on one side that is much bigger than the other. But the actual contrast kind of shows you whether or not, there's like, it could potentially be like a necrotic mass because it will look different. It'll be more enhanced around the edges and then be darker in the center. But there is something else that she mentioned. She did mention it in both that are specifically relevant to needing a CT with contrast. Does anyone remember what she mentioned? Or know what the relevance of it was? She mentioned a blood test that had been taken, EGFR. Yeah. Does anyone know why that's important? AKI, yeah. So contrast can induce an acute kidney injury. It is nephrotoxic. So in patients who have an EGFR of less than 60, I believe, they would need extra fluid before and after that contrast. So it doesn't mean that they can't have one. It just means that they give them lots of fluid to try and flush it out and expand the blood volume. This patient has an EGFR of 78, so that's fine, no issues for her, but it's really important that that one has been taken. So if you're seeing patients in A&E and they need a CT, make sure that they've had their bloods done and that the results are back, because the radiologist will not say yes to your CT until they know what that number is, because it has a big effect. There's also something else that she mentioned. She says she's not on any medications. Anyone know of any medications that affect your CT request? Yeah, metformin. So metformin is basically, it's the same mechanism via just the it basically makes you more likely to get a contrast-induced acute kidney injury. So again, patients with this is a bit lower, I think. Patients with an EGFR of less than 40 need to have their metformin withheld before and after. The Royal College of Radiologists does say that they can have contrast if their EGFR is over 40 and on metformin. But from personal experience, I know everyone is very jumpy about giving contrast to patients who are on metformin, have recently taken it. So if they can, they prefer to hold it for 48 hours. It's quite serious. Like I remember when I was on my renal placement at medical school, a patient actually died of a lactic acidosis from because people didn't realize that they were on metformin. They went and had this CT. Obviously, they had a renal problem because they were on a renal ward. So it's not a small thing. So yeah, it's really important to know, again, when you're requesting these things, your patient's past medical history and any medications that they're on. So yeah, some tips for radiology. So I've put, make sure you're speaking to the right person, because there's so many people that work in radiology. So there's radiographers, there's CT specific radiographers, ultrasound radiographers, the actual radiologists. So you want to make sure that you are speaking to the on-call radiologist or the hot radiologist, because they are the ones that, they are the consultants or registrars, and they can actually approve the request. And it's also really important to know that if you make an urgent CT request, obviously you put the thing in online, you need to call them and ask them, to formally approve it, because if you don't, it just gets put on a general list and could get done in 2 weeks, 3 weeks, who knows. So an urgent CT request that needs to be done within the hour, even on the day, you have to call them. If you tell them why you need it done urgently on in the conversation, again, it just keeps things nice and clear. and makes it easier for them. They get so many of these requests every day. So, you know, all these important factors that Shona mentioned in the second one, you know, the airway compromise, the fact she needs to go to theatre, she's septic, all of these things should be pushed, because that's going to push this patient higher up on the list, you know, of the CT waiting list. As I said, you need to make sure you've got the patient's medication history and the current EGFR. So the EGFR menas, basically, if a patient has reduced renal function, contrast is cleared by the kidneys and it's toxic to the kidney. So if you can't clear it fast enough, you can get an acute kidney injury. So patients with an EGFR of less than 60, I said, would need extra fluid before to expand all the blood volume. They give them the contrast, and then they give them some more fluid to flush it all out, to reduce the impact on the kidneys and causing a problem with that. Does that make sense? Yeah, so if the patient is stable, the EGFR can be within the last 3 months. So, you know, say if you're on clinic or something and you're ordering a CT scan, you know, for a suspected cancer, if the patient hasn't had a blood test that day, but they had one, say, a month ago, that's fine. And yeah, make sure that you've ordered the correct imaging. So this is sometimes, you know, this kind of relies on you having a bit of knowledge, but also if you don't know, just clarify with your reg. You can't actually order a CT without the, basically, it's actually the registrar that formally, well, doesn't have to formally order the CT on the system, but anyone who's kind of the grade more junior to a reg can't make the decision to order a CT, is what I'm trying to say. So any CTs that you request and things, you might notice, especially if you call 4 ways, like the external reporting service overnight, they will ask you the name of the registrar as well that you've spoken to. So yeah, clarify exactly what needs to be ordered. You know, is it fine? You might be looking for a neck abscess or a fractured mandible, but do you need a CT neck and mandible and facial bones? Do you need the brain included? You know, what exactly do you need? And do you need it with or without contrast? This is really important to know that, because if they take, if you're looking for an abscess and they take it without contrast, and it's a small abscess, and it could be almost useless, and we don't want to have to submit the patient to being re-exposed to yet more radiation. And yeah, as I said, just make sure, ask your reg if you're not sure exactly for what you need. So yeah, just some kind of take home points here. I'll hand back over to Shona.
Yeah, so as we said, we've laboured, always make sure you've got as much information as possible, and everything in front of you, because the last thing you want to be doing is scrambling about, trying to find all the information, and the other person on the phone isn't going to appreciate that either. They're likely to get annoyed at you. Check which investigations have been done and any results, and have them to hand as well. Ensure your diagnosis or suspected diagnosis is said early on. So try and have it in the first couple of sentences so they have no idea, they know what you're phoning about, and let them know if you're worried about any deterioration or anything like that, and let them know that early. Waking up someone in the middle of the night, be direct and give them a couple of seconds just to orientate their brain. And use the SBAR approach when asking for a review by anyone. But also when you're taking referrals, so if someone's asking you, you can, hopefully they'll use that format with you, but you may need to ask them questions as well. Yes, I think that's it for that slide, and then we'll move on. So these are just some tips on who to call. So if you've got a MaxFax issue, you're obviously going to call your MaxFax registrar. So anything in A&E, anything about your sort of ward patients, which is to do with them, you'll always phone them on the first port of call. If you're concerned about the airway, then you're going to be calling your MaxFax reg as well. They will contact a consultant too, but it would be them who would contact a consultant, and also contact anaesthetists. The regis aren't always on site. Neither are the consultants, but anaesthetists will always be there, so they can get there quickly if you've got an airway emergency. So medically unwell patients, you're going to call the Max Fax Reg first, and it's them who will tell you to contact the Med Reg. So don't contact the Med Reg first, always ask your registrar first. And that's if the patient is reasonably stable. If the patient is very unstable, then you're wanting to thinking about more critical care outreach. So things like ICU or HDU, and ask them to come and review the patient. If the patient has abdominal pain and they haven't vomited any blood, then you're going to contact general surgery. If they have vomited blood, then that's gastroenterology. And out of hours, that would be the medical registrar again, because they would pick that up after out of hours. As we've just laboured in the last case, all urgent radiology and imaging needs to be vetted by a radiologist. So if you want something done, especially through the night, you need to phone and ask for it. If you've ordered a chest X-ray in the middle of the night and you want it done, it's not going to get done. You need to phone about it. And any CT scan that you want done urgently needs to be phoned. Antibiotics, you'll be phoning microbiology, as we have done in the case demonstrated. Medications and hours, you're going to be asking the on-call pharmacist. If you're struggling with getting bloods or bloods or a cannula in, you can get the out of hours team who can be helpful, but if they're very difficult, you might need to call the on-call anaesthetist, and they can they can help get cannulas in with the ultrasound, and they're the best people to call for that. And if you're struggling with pediatric blood taking or cannulation, you've got pediatric nurses, pediatric SHO who's on call, and the out of hours team as well. Great, and that is us.